Good afternoon, everybody. As always, it's a pleasure to connect with all of you representing the India Smile Train Medical Advisory Council. So our topic today is going to focus on the management of individuals with velopharyngeal dysfunction. So in the previous webinar, we focused on the assessment aspects where we looked at the different aspects of assessment, including clinical assessment performed by a surgeon and a speech language pathologist. And we also saw the instrumental procedures that can be used, including nasoendoscopy, pharyngoscopy, and some of the indirect methods that can be used for the assessment. Now, taking that forward, today's webinar will focus on the management aspects with Dr. Karun Agarwal first laying down the link between the previous webinars to this webinar, wherein he will be talking about the decision-making regarding surgical intervention. So how do we use the information that we find in assessment to go ahead with the intervention? So that would be the groundwork for today's webinar, and it would be laid by Dr. Karun Agarwal. Following that, we have different techniques for VPD management that will be discussed by Dr. Krishnamurthy, Dr. Mukund Reddy, and then Dr. Karun Agarwal. Following that, we will have our anesthesiologist on the team, Dr. Baljit Singh, who will be presenting about airway management following pharyngoplasties. And then we would end this with the topic that's close to my heart, that is speech therapy following VPD surgeries. So that's going to be the outline for today's session. So without spending much time further on the introduction, we will dive into the topic straight. May I request Dr. Karun Agarwal to please share his screen and go ahead with talking about decision-making regarding surgical intervention. Dr. Karun Agarwal.
So good afternoon, everybody. And I welcome such a large gathering for this interesting topic. I'm sure there will be some take-home messages out of this presentation. And I'm extremely happy to start the ball rolling. And this is, as Dr. Savita introduced, this is basically a groundwork for the groundwork and the link between the previous webinar which we had on the assessment of VPD 9-10 days back, and then we'll take it forward. Now, a brief recap what we talked about is the VPD assessment is to be done based on the clinical assessment of the clinician in the OPD, perceptual assessment by SLP, then the instrumentation, that is nasoendoscopy and video fluoroscopy, and some of the indirect assessment methods, including the nasometry. So these are the armamentariums which we have for the assessment of VPD in our setup. Now, what are the elements we see during assessment, which I ended my presentation last time with a similar slide. And this is a nutshell that we see the degree of speech abnormality, which is very well essentially supported by SLPs. Then by instrumentation, we need to see what is the type of velopharyngeal sphincteric closure during speech. Then the gap in the velopharyngeal sphincter during speech, we can call it as distance between the genu of the soft palate with the posterior pharyngeal wall, and or the ratio, the closure ratio of the velopharyngeal sphincter. Fourth is the dominant element of the velopharyngeal sphincter, which has got important role in decision making. And lastly, the other elements, that means there are 4 walls of the sphincter. One is the dominant, other 3 walls, how much active they are, or they are not participating in the closure of the velopharyngeal sphincter. So these are the 5 elements of our assessment in velopharyngeal sphincter, velopharyngeal dysfunction assessment. Now, when we talk about the speech assessment, this is the one which we use in our setup is the Pittsburgh weighted speech scale. And this is the scoring which our SLP gives. This is essentially to know what is the degree of competence or incompetence of the sphincter. So this, based on the score, we say it is competent or it is incompetent or it is borderline, but it does not have true role in the management per se in decision making. Only thing it tells about the now who decides? Ideally, this decision of surgery or speech therapy or speech therapy and surgery, this is to be a combined decision. This is to be decided by the surgeon, speech language pathologist, and what is also very important is the part to be played by the child as well as the parent. So these four pillars of the decision makers must be considered while taking decision about the surgical protocol or the surgical intervention in this type of surgery. I have many children who have objectively abnormal speech and there is a degree of incompetence, but they do not want to have the surgery done because they are already in IIT, they are already doing post-graduation in medicine. So they are very well adjusted and they do not want. Objectively, as far as surgeon and SLP are concerned, we will like to go ahead and do something to operate upon, but they have to decide with the consultation with the child and the parents. Also, we need to answer within our team that will the speech therapy itself will improve the speech or speech will be improved with surgery and followed by speech therapy. So these are the joint decisions and the protocol or the methodology of our management to be laid down before we really decide for the surgery. Now, when the team decides that we have to go for some surgical correction of velopharyngeal dysfunction, then I follow three principles. This is not a written principle anywhere else, but over a period of time, I have laid down these three principles. And this is there in the literature also, that one needs to use a technique which is physiological. We must have a physiological so that there is a dynamic closure of the sphincter rather than achieving only physical closures, because the physical closure will not give dynamism to the sphincter and give a good speech. Hence, the physiological closure is important than the physical. Second principle which I followed is, since the palate is the most active element of velopharyngeal sphincter, most of the surgery should aim at improving the length and mobility of the palate primarily. And third, whatever remaining gap is there after palatal surgery, we should try to close or cover by pharyngeal surgery so that there is no air leak through the remaining area of the sphincter. Now, what are the surgical techniques which we have in our armamentarium? One is the palatal surgery, which could be lengthening, or muscle sling redynamism or reconstruction. And second group is about the pharyngeal surgeries, which are either narrowing or attempt to increase the mobility of the elements of velopharyngeal sphincter. Now, amongst the palatal surgery, if we give the name to the surgery, surgical techniques, there are furloughs, that is double opposing Z-plasty, buccal myomucosal flap, intravelar veloplasty, and radical muscle dissection. We'll go by one to these techniques in the next presentations by Dr. Krishnamurthy and Dr. Mukunda Reddy. And the pharyngeal surgeries are dynamic sphincter pharyngoplasty, pharyngeal flap surgery, especially the superiorly based pharyngeal flap, and augmentation pharyngoplasty. Now, how to choose amongst these 6-7 surgeries, how we decide about which one to use in which patient. Now, this we decide based on three titles. One is the condition of the soft palate. Second is the velopharyngeal sphincteric closure, type of the closure. And third is the mobility of the elements of the velopharyngeal sphincter. If we see these soft palate, if it is short, scarred, badly operated primarily, breakdown is there, muscle dehiscence is there. On endoscopy, you see the grooved palate indicating that muscle is not united well. Then obviously we have to do the palatal lengthening surgeries, which is mainly the furloughs and the intravelar veloplasty with or without buccal myomucosal flap. And radical muscle dissection is practiced by some, but it is not very popular because of the intricacies of surgery under microscope. Now, let us come to the type of velopharyngeal sphincter closure, which is decided based on the nasendoscopy. And this closure we see in 70% of population, as we discussed last time. if there is a small coronal gap, if we see this is the coronal gap, coronal closure, this is the coronal closure. If it is a very large closure, small gap is there, then we can manage with palatal surgery because palate can be pushed back and it can close. But if it is large, significantly large, then palatal surgery may not be adequate alone. So in that case, dynamic sphincter pharyngoplasty is used. And when it is less than 3 millimeter gap, 2 or 3 millimeter gap, and very small gap is there, augmentation can play a role in the improvement of function. Now, second type of closure is the vertical closure, that is sagittal closure, which occurs in 5 to 7% of patients. And in these cases, because you see there is a vertical gap, in this, the superiorly based pharyngoplasty flap is ideal, and one has to use the line flap, which we will come to it later when we talk about the techniques. Third type of closure which we see is sphincteric closure, which occurs in 25% of people. And this is a group of patients where we can use either the dynamic sphincteric closure or we can use the flap. But I practice mostly the dynamic sphincteric closure because I am very comfortable with this. And I consider it as not too non-anatomical. So that's why I use this. And if the closure is of unequal type, one side is closing, other is not closing, just like this, unequal closure, then one can use the unequal sphincter pharyngoplasty. One can tailor make the sphincter pharyngoplasty to close such gap which is unequal on two sides. Now, if based on the mobility of the palate, if we see, if there is anything active, whatever active element is there, that should not be harmed by any chance. An inactive element should be used to advance medially or centralized so that the closure is advanced. And if the aim is to narrow the velopharyngeal sphincteric size by operating on the inactive element in the pharynx. So these are the three headings by which we decide, and these are basically based on the nasendoscopy. Now coming to a finding based on the lateral video fluoroscopy, which is the gap between the genu and the posterior pharyngeal wall. The literature says that if the gap is less than 9 millimeter, then palatal lengthening is good enough. And if it is more than that, then one has to use the pharyngeal surgery with or without palatal lengthening. But now over a period of time, even Dr. Mukund will vouch that now the distance between this gap is coming down and people are coming right up to the 5 millimeter or 6 millimeter gap to use the palatal lengthening. If it is more than 5 or 6 millimeter, people tend to use other techniques. So in nutshell, the VPD evaluation, if there is a short palate, if it is less mobile, if it is grooved palate, that means soft palate issues are there, then it is palatal surgery. If minimal gap is there, then any type of pharyngoplasty can be done. If it is a moderate or sagittal gap is there, flap is to be done. And when it is large gap, then sphincter pharyngoplasty needs to be added along with the palatal surgery. But palatal surgery remains an integral part of all types of VPI surgery. So final aim of any VPD surgery is to attempt a good closure. Just like these two examples are there, there should be good closure. And one has to think logically how this can be achieved based on your objective assessment, which we have seen with this endoscopy and or video fluoroscopy. Now, most of the time I'm asked these three questions, which I'll come to. One, I'll answer them before you ask me these questions. One is it possible to perform VPD surgery without nasendoscopy or video fluoroscopy? Definitely not. We cannot justify performing any type of surgery without having an objective assessment. These tools are there to guide us for the selection of the pharyngoplasty or palatal surgery, as we have discussed in previous slides. Second common question is it possible to perform one procedure for all types of cases? Again, the answer is no. Obviously, because we need to have a large armamentarium so that we can justify this surgery for a specific type of condition or a specific type of gap, which we see objectively. And third, can one perform VPD surgery without a speech therapist? Because large number of people may not have SLPs in them, but one can perform VPD surgery without SLP. There is no doubt surgery is surgery, but the result will be suboptimal. And one needs to oil any machine if you are repairing. That is true for any automobiles also. If you repair a machine, you need to oil. And SLPs are the right people to put the oil at right place for the tongue movement, for the pharyngeal movement, and for the development of the velopharyngeal sphincter and dynamism to the palate. Hence, it is not discouraged. Thank you so much.
It's very interesting to see the algorithm that has been put forth by Dr. Karun, beautifully summarizing all the different aspects of velopharyngeal assessment. And I think his presentation very rightly conveys the message that it is definitely not one size fits all. There are a wide variety of procedures from which one has to choose what would be appropriate and then go ahead with the surgical intervention. Fine, while you may take time to churn out your questions, please feel free to type in your questions in the chat box. We will take up any questions as we get them and we finish the next upcoming presentations. So without wasting much time, may I request Dr. Krishnamurthy to please go forward with presenting about Furlow's Z-plasty.
Good morning, good afternoon, good evening to all of you. I'm not confused, but I know that we have people from around the world. As I was scrolling through, I saw people from all over the world, from Mexico, where it must be very early in the morning, from Indonesia, where it's very late in the evening, from Africa, where it's afternoon, and of course, India, where it is evening. So, though we are meeting in the backdrop of a tragic drama playing itself around the world, it is Smile Train has allowed us to try and convert this into an opportunity. Thanks to Smile Train for arranging these things. We are learning a lot, and it's a great pleasure to see more than 200 people from around the world. My remit, Savita, my time starts now. My remit for the next 15 minutes will be to talk about the role of Furlow's palatoplasty in the management of VPD, and I will stick to that. My thanks are due to my team, particularly Aparna, who is my speech pathologist, and Preetham, who is my colleague surgeon. So this is a surgical procedure. If you look at cleft graft, came in very, very late into evolution. Furlow described this double opposing Z-plasty in the primary repair of cleft palate only in the year 1986. So for those of you who are not familiar, this is a double Z-plasty. What you see on this slide, the one with the dark line, which is not dotted, are the Z on the oral mucosa, and the dotted line is the Z on the nasal mucosa. So you do Z on the oral mucosa and a reverse Z on the nasal mucosa, as a result of which you get one flap that is posteriorly based and another flap that is anteriorly based. The flap on the oral side, which is posteriorly based, you take the muscle. Similarly, the flap that is posteriorly based on the nasal side, you take the muscle. The other anteriorly based flaps are oral, and then you reconstruct the muscular sphincter as you see here, and then close the wound in as a Z-plasty. So this question has already been answered to a certain extent by Professor Agarwal. He said that the most important importance should be given to a physiologic attempt at VP closure from the days of depending only on pharyngoplasties or reducing the port through which air escape. We have come a long way, and various techniques, as he already outlined, have come in. As far as my literature reading goes, it did not take long for people to latch on to this Furlow's palatoplasty as a secondary technique to correct VPD. If you saw Furlow describing this technique in 1986, I see a paper appearing in 1994, none other than the Shangang team with Philip Chen as the first author, who described in 1994, within a few years after this technique was described for primary closure for repair of VPD, because it's physiologic. Here we can get the levator muscle, not trying to disturb the balance so much, along with the mucosal layer, take it posteriorly so that not only the resting position of the muscle become closer to the posterior pharyngeal wall, but you also have reconstituted the sphincter so that when it functions, it can go and close against the posterior pharyngeal wall. That is the logic. We know we are going to talk about the other techniques. I have a short video. This was shot many years ago by surgery done by my colleague, Dr. Shetty, who is in this audience. It's a quick recap of how to do a secondary furloughs. There are a small little modifications that currently we have incorporated over the years, but I couldn't make a new video during these times. So you'll have to see that. It's a good one. Like I said, a Z-plasty with the anteriorly based flap side and a posteriorly based flap on the left side. So what is cutting now is the posteriorly based flap. Along this, with this layer, you take the muscle as well. So as you go along, because this is posteriorly based flap on the oral mucosa, you take the muscle. Try to get deeper into the muscle, and you can undermine the muscle till you reach the levator tunnel, so that you know, as he's now dissecting, you know that we are now taking not only the mucosa posteriorly, but also one half of the palatine musculature, the levator musculature, onto a posterior extent, which will move the musculature closer to the posterior pharyngeal wall. Because one of the things that Philip Chen described is the deepening of the palate when you do furloughs palatoplasty. So now on the right side is the anteriorly based oral mucosal flap. This is taking up only the mucosa. You have to be very careful when you do this, because oftentimes these mucosal flaps may be very scarred and the thickness may not be adequate. There is, now we are doing the reverse Z very quickly. That was a posteriorly based nasal flap with the muscle and the anteriorly based mucosal flap of the nasal layer. So that's all there is to it. I apologize if it was too quick. I'm sure Mamta will give us an opportunity to demonstrate this in a leisurely manner if you're all interested. That using the mucosal layers. With this elegant technique that Furlow described, Furlow was a very, very modest chap. We've all met him at a meeting in 2008 at, was it 2008 in US, and he was a very, very modest man. But I think the concept was brilliant. There you see the muscular dissection being deepened. We have finished with the mucosal layer closure on the nasal side, particularly anteriorly. You can cut as you go along. When you take this oral mucosal layer, you're also taking the muscle. Remember, the muscle is on the posterior aspect, and here we are taking a bite across the muscle. So we now know that we have reconstructed the muscle sphincter, and we have taken it so far posteriorly from the edge of the hard palate. Occasionally, if you find that these mucosal tissues are too tense or not yielding, you could add a buccal flap, particularly in the oral or the nasal layer, as the case might be. So we'll go on. That is the technique. So we will now look at, so we have used this Furlow's palatoplasty now for more than about 13 to 14 years. It took me a long time to learn it, but recently we have analyzed what are the things that makes this technique a good one to use. We have looked at results, and then we have tried to analyze it to find out whether it is possible to predict the outcome. Remember, we heard from Karun Agarwal that a single technique cannot be useful in all circumstances. You may be able to use this one in certain situations. You may have to add something else, as Dr. Reddy will show you a little later when the problem is different. And therefore, it is important for us to know that where does this kind of a technique work and where it does not work. And we have looked at our results of about 92 cases that we have performed. The parameters that we have analyzed here, we have done the pre-op lateral video fluoroscopy. The last time in the assessment, I covered lateral video fluoroscopy. We don't do nasoendoscopy for all our patients, but if required, we do it. But in this study, which is retrospective, we have looked at the pre and the post video fluoroscopy. looking at the closure ratio, as the last time I mentioned how we measure the closure ratio. In addition to that, very importantly, we also did perceptual speech assessment, both pre and 6 months post-operatively. Perceptual speech assessment includes the various parameters here: the hypernasality, the nasal air emission, the understandability, the acceptability, and articulation. Don't get fooled by all the surgical talk of various techniques of lengthening the palate, lengthening the pharynx, reducing the port, etc. The bottom line lies at how better the speech for your patient got. In other words, whether you get velopharyngeal closure or not, whether you have a slight nasal air emission or not, what will ultimately matter to your patient and parent is speech understandability and acceptability, and we will always have to judge our results against that. This is what I showed you yesterday, papers from Somalad, etc., showing how to measure. Basically, we are going to look at velopharyngeal gaps. So if you have no gap at all, or the ratio is 1, it is complete closure. 0.8 to 0.9 is efficient closure. 0.4 to 0.7 is intermediate. 0.1 to 3 is inefficient closure. We will be using this terminology. So I will now play you videos of a few patients pre and post-operatively, and also tell you what was the pre and the post-op speech assessment and velopharyngeal closure ratios for each one of these patients as we go along. This is pre-op.
Susi Samudra Sutinalo.
60 to 74 more, 60, 61.
60, 61, 62, 66,
Okay,
64.
that is post-op. All of these have
61, 62, 63, 54.
You see, there is a
55,
genu, but there is
66.
also a small Passamas ridge coming up. So what you
Susi
found here
Samudra.
is that this patient had a closure ratio of only 0.4, and she had moderate hypernasality and nasal air emission. And post-operatively, she has complete closure. She has normal nasality. She did not need any therapy. This is the ideal case scenario. Does not happen always. Let's look at case 2.
Pa, pa, pa.
Pa, pa, pa.
P, P, P.
P, P, P.
Poo, poo, poo.
Fu, fu, fu.
Let's stop it there. Let's look at post-op.
T, T,
Pa, pa, pa.
T, T,
Beep, beep, beep.
Excellent genu and closure you can see there.
Beep, beep, beep.
Okay, we'll stop there and go to the next slide.
Pa, pa, pa.
Sorry, I just want to look at the results of that slide for a second. So this one had a slightly better pre-op closure ratio of 0.6, moderate hypernasality and nasal air emission. Did not get complete closure, 0.96, but required speech therapy, but ended up with normal nasality with some nasal air emission. Then we'll go on to case number 3, pre-op, case number 3.
A,
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 E,
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 U,
Okay,
U,
you'll see the post-op.
U,
See the nice genu,
A,
E,
excellent
E,
movement.
U,
pa, pa, pa.
Pa, pa, pa.
P, P, P.
P, P, P.
What are the important things that I was mentioning
T, T, T.
T, T,
earlier?
T.
The sustainable movement. You see the soft
Ki, ki, ki.
palate stays there, very close to
2,
posterior pharyngeal wall,
3,
so that it doesn't have to make
4,
rapid
5.
movements up and down. That I think is an indication of a good
Ah.
repair, which is normal. So she also had closure ratio of only 0.5, moderate mild hyponasality, ended up with having a phoneme specific nasal air emission, otherwise had normal speech understandability and acceptability. Case number 4 now.
A,
E,
E.
There is a big Passamas ridge coming in down at the inferior level of the soft palate, as you can see there,
E,
and significant amount of hypernasality, as I can see.
sa, sa.
2, 3, 4, 5, 6, 7, 8.
Okay, so if we go back and look at it, he also had 0.6. So we have a patient, the first 4 of them having an average of 0.4 to 0.6, but as the closure ratio ending up with 1 or 0.96. We move on to case number 5. Sorry, case number 5.
Pa, pa, pa.
Pa, pa, pa.
Obviously a big gap.
Beep, beep, beep.
Obviously a big gap.
Ba,
We move
ba,
on to the
ba.
post-op.
A, a, a.
A, a, a.
Pa, pa, pa.
Pa,
Okay, so this patient had 0.45 closure and ended up with 0.98. Except for the first patient, all of them needed of speech therapy. You have to be noted. The last two cases will show very severe hyponasality. Sorry, very severe lack of closure. And post-op. Nice, Genu. You can still see a small gap, but what does the speech pathology say? Speech pathology says that in this case, the speech therapy is an ongoing thing. Had severe hypernasality, as you can see, as you would expect with a closure ratio of 0.26, has now become normally nasal, but the speech therapy is going. And the last case is the one I put up last time. We also had his speech samples last time, a 5-year-old boy with a very severe hypernasality and very poor velopharyngeal closure. And there is his post-op.
61, 62, 63.
Okay, so does it mean that we can go on and do Furlow's palatoplasty in all these cases, irrespective of the closure ratio? That is not true. We found that hypernasality reduced or became normal in about 72% of our patients. In 70% of our patients did not have nasality. At the end, about 70% had good understandability, but only about 60% had good speech acceptability. Notice the difference. And closure ratio, in about 50% of the patient, we got complete closure or efficient closure, and the rest in smaller proportions. As you can see, there was a mean increase in closure ratio of about 0.3. That is what we see. Looking at all these parameters, we tried to make a prediction as to, I just have a minute. Savita, can I take a minute more? So looking at all these multiple parameters that we measured, we tried to aim at a formula to see what are the preoperative parameters that told us that post-operatively you will get a good closure. So we found out that understandability and acceptability were not good predictors, but hypernasality, nasal air emission, and pre-CR were good predictors. This is the formula. Basically, don't worry about this. With this formula, you can predict what is likely to be the post-operative closure ratio, based on which you can then say this procedure works in these patients. There is a whole lot of papers in the literature which looks at different aspects. In most of them, you will find that the parameters measured are different. I don't have time to go through it, but to say that Furlow's palatoplasty, it's a physiological surgical option. This is something you see coming out through the literature, that if you do a careful speech assessment, irrespective of the other parameters that have been studied in the various studies that I put up, whether it is nasopharyngoscopy, video fluoroscopy, nasal air emission, etc. One thing was common in most of all the studies. They looked at perceptual speech assessment. Therefore, don't get fooled by all the instrumental measurements that we are talking about. It is important to make a decision, to see what happened later on, but the proof of the pudding is to see how well the speech improved after surgery. So perceptual speech assessment, particularly speech understandability and acceptability, how much they improved will remain the gold standard. And you find that with one single technique, it is not possible to completely eliminate velopharyngeal dysfunction in all cases. But if you carefully do a speech assessment, do your video fluoroscopy, you can then predict your outcome and then develop an algorithm rather, for management of VPD. I think we are not there yet. There's a whole lot of confusion and controversy, and we can discuss that later. Thank you very much.
Thank you, Dr. Krishnamurthy, for that wonderful presentation. There's just one question that has come in the chat box that you could answer. Is there any minimum? Is there any minimum age limit for performing VPD surgery?
Right. So we discussed this last time. This will depend upon when the speech and language pathologists like you picks up a velopharyngeal dysfunction and starts wanting to assess. And in our setup, video fluoroscopies can be done at about 5 years of age, when the child will obey commands and start reciting whatever speech samples that we want to assess. So for us now, it is around 5 years of age. The limitation is the ability to do an instrumental assessment for a child, be it video fluoroscopy or nasoendoscopy. Earlier the better. But the first in the SLP score to decide there is a strong suspicion of VPD, and then confirm it with the assessment. We do it at around 5 years of age.
Yeah, and as far as the speech pathologist is concerned, from our point of view, the only criteria that we would want to meet is the child should have sufficient words in the vocabulary or sufficient language development to be able to speak in simple 2 to 3 word sentences. That is the criteria that we look at. Once a child has that level of language development, we are able to go ahead with this.
And in your experience, do you do it much earlier than what we do, or is it around
no,
the
it's
same
normally
age?
around five years.
Yeah.
5.
Okay.
Five is also like, sometimes we do give it an attempt at 5 and we may not succeed always. It depends on how much the patient is able to cooperate. But
I agree.
That's when we give it a try.
Right,
Are there any
I agree.
questions? We have a couple of minutes we can break for discussion here. Are there any questions from the audience?
Yeah, just a minute. There are a few questions. I think this question is for you, Savita. I'll just list them out, and if this is not for you, feel free to redirect it.
Yeah.
Someone is asking that if a patient has undergone a palatal surgery at 3 years, but has not undergone speech therapy, now has hypernasality at 6 years, should we proceed to surgery or should speech therapy first?
This would depend on what is the profile that we are seeing at 6 years of age. What are the characteristics that we see beyond hypernasality? How much of articulatory errors are present? Is the child attempting oral productions? So usually if we have a child who is not attempting any oral production, then we would prefer to take them in for speech therapy first and then go ahead with testing for velopharyngeal dysfunction if hypernasality persists even after that. But if the child does not have much articulatory deficits, it's only hypernasality, sometimes along with nasal air emissions, then even if the child has not attended any speech therapy, we can go in for VPD assessment. So therapy is not the criteria there. The criteria would be what is the profile of the patient. That is what we need to look in for. So a speech pathologist has to do a thorough assessment, profile the characteristics, and then based on that, we would be able to take a call on this.
Savita, can I come in?
Yes, Dr. Krishnamurthy.
So what you're saying is that in circumstances, you may not do any therapy. You would straight away assess for VPD, do the surgery, and then do therapy, whatever is required, even in this scenario, correct?
Yeah, if the child is not having any articulatory error, yes.
Right, okay.
There's another question. Please tell what, if you will prioritize the tools for assessment which are sufficient if we select 2 or 3.
Can I take that, Savita?
Yes, Dr. Krishnamurthy.
So everybody needs to have a perceptual speech assessment. I don't think we should try to correct any form of VPD without that. I think it is just like pouring what do you call oil into fire. You're just going to worsen the matter. You need perceptual speech assessment. Number one tool of assessment, and then you need one measurement, which may be a video fluoroscopy or nasoendoscopy. So you can do with only 2 of them: perceptual speech assessment and nasoendoscopy, or perceptual speech assessment and video fluoroscopy. That too lateral video fluoroscopy. With these 2 measures, you can manage in most cases.
Okay, thank you. There's another question which says that kindly opine in which scarred palatal cases for furlough, I think he means furlough, not to be done for treatment of VPD.
Right. Can I take that, Savita?
Yes, Dr. Krishnamurthy, furlough is all yours.
So one thing I found out as I did more and more, somewhere our own palate, somewhere people operated elsewhere, that oftentimes there was a lot of mucosal scarring and tethering, which I think dragged the muscle also with it. And as you release these scars and did the Z-plasty and rearrange the tissue, the very fact that you were breaking the scars, the very fact that you didn't have to bridge a gap like you had to do in primary surgery, I think itself is an important determinant in the success of this technique. But I cannot quantify. Therefore, whatever be the level of scar, I would do this. Earlier to doing these furloughs, I tried my hands at doing a radical muscle repair, as Professor Karun Agarwal said, and I found that oftentimes in very scarred palates, I couldn't find any to rearrange. Whereas in case of furloughs, because you're taking the mucosa with it, you have the additional insurance of more tissue, and you can carefully dissect and find it. So I think whatever the level of scarring, I would still do it, provided the other parameters. Like I said, my predictors tells me that if the closure ratio is above 0.5 or so, there is definite predictability. Though I showed some cases where 0.2 also showed closure, but those are the exceptions what I showed. Based on the formula that we have worked out, anybody above 0.5 closure ratio, you can go ahead and do it. However, if there is, when you do the surgery, if you find that the tissue is not sufficient, you can always borrow a buccal myomucosal flap. Dr. Reddy is going to show some examples of buccal myomucosal flap. So you can alter the decision and then add it on. It's not necessary that you have to stick to a pure furloughs.
May I request Dr. Mukund Reddy he's already shared his screen and he's ready there to go ahead with presenting about the buccal flap, the Schen's pharyngoplasty, and the suspension pharyngoplasty.
Good evening, everybody. Like Krishnamurthy said, it may be good morning and hopefully not good night. Anyway, I start my talk today by paying a homage to this great soul who incidentally was my chief guest at a workshop which I did in 2018 in Hyderabad, mostly to demonstrate how to correct VPD. He's a great man, as many of you know. He was a role model for many of us and taught us by example cleft care to all the Indian plastic surgeons. He was an inspiration and will continue to be for a long time to come. I don't know about these lines, how did they come? Anyway, he was in the meeting in Hyderabad, and as you can see, he was all attention. He participated, and without him, it would not have been the same. Thank you, sir. Now, coming to today's surgical management of VPD, Krishnamurthy has mentioned how exactly to do furloughs. And furlough has been the basis of my own surgeries for a long time. And like he mentioned, they can correct in 60 to 70% of the cases if he demonstrated the closing ratios. And if you do an endoscopy, Philip Chen mentions about 30% closure. If it happens, then it's going to help you. Otherwise, you will have to use a different method. Let me just point out a few things in this video fluoroscopy of a normal individual. Just look at the gap here, which is normal gap, which is usually about 7 millimeters, according to studies which we did. And this pooling is at the eustachian orifice. The closure is approximately here at this angle with a knuckle. And the middle of the soft palate, this part is actually what moves. So you need an arm which helps it to move. There, it touches near that part in every case. And if you look at a case of VPD, you see the gap. It's obvious that it's much more than 7 millimeters. When it's a centimeter or more, the movement of the pallet is always same, is about 7 millimeters. It's not able to reach this place just because the gap is too big. So if you do a furlough in a case where the resting gap, Karun has mentioned about the gap, 9 millimeters as the one which they would do that is a resting gap. What I would decide is the gap when it closes, what is the remaining gap? If the gap is substantial, then it's unlikely to close. See this? It moves, but ouch, it doesn't reach till the roof, despite this perseverant ridge coming to its help. Therefore, that forms a guideline for us to decide what to do if you are using a video fluoroscopy. That was the basis for devising a procedure so that you can position your repaired pallet as close to the roof as possible. And we said it's less than 7 millimeters, then it would close. So we are aiming to put the pallet at 5 millimeters from the roof so that the movement of the levator will be able to close this. This is a patient whom I operated at the workshop. I'll use this as an example. It starts with a perceptual assessment.
61, 62, 63, 64, 65, 66, 67, 68, 69.
That's adenoid, the movement. The gap is lower there. It's about moderate gap. So it starts, all my procedures starts with a furloughs type of incision, which usually is a 60-degree angle nearer the palate, the anterior one. And then it's a right-angled one incision more posteriorly because we want to reposition the muscle more posteriorly in the palate. The flap, which I am talking about in suspension palatoplasty, comes from that is the adenoid, what you see, the bulges. So lower 1/3 of the adenoids is the place where I would base my flap. It's a centimeter wide and about 2 centimeters long. That is a flap being marked. You can see this right on the lower 1/3 of the adenoids. The incisions are made through the muscle right up to the prevertebral fascia level, so that all the muscle should be included in the flap. Such a thin, small flap, if it's just mucosa, it would tear. So having made the incision, you see the white structure where I've gone is the prevertebral fascia. Then I use the scissors to dissect the muscle. This flap can either be done as being shown before you do the Z-plasty, or you could do it after the Z-plasty, but that you will have to go through a retraction process and then do the same thing. Normally, I would close the donor area and keep it ready for transfer. That's the scissors being used to lengthen the flap by just pushing it and dividing few of the muscle fibers. Then we start with the furloughs as has been demonstrated. So I will not repeat what has been shown so nicely by Krishnamurthy, but I will, most of the times what I am asked is, they would ask me to show where exactly I would insert the flap. That's a mucosal flap to which the flap is being attached. The flap is attached to the edge of the mucosal flap on the nasal side. So that means you are attaching to the soft palate exactly in the muscle where the knuckle forms, so that you are pulling the palate upwards to meet the roof easily. Makes the effort of the palate much easier so that it can close without too much of a difficulty. Then the cut flaps are also anchored to the base of the flap. This is the suspension part. In the sense you are physically suturing it to that is the base of the flap, to which the mucomuscular flap on the right side is being anchored with this stitch. Couple of stitches are enough to pull the palate there. After that, the muscle, of course here sometimes you cannot demonstrate the muscle. It's a bundle of scar and muscle. On both sides is taken, and then it is anchored to the flap, base of the flap as well, taking a bite. That's the one which is being tied. The view is from the other side, from the foot end of the patient. That's why it looks different. Then it's closed. The oral Z-plasty as usual. But if you look at, this is not the same patient. This is where the flap is. The post-op nasendoscopy, you can make out that the flap is here, and you can see that the palate has been lengthened, plus the gap is maybe 5 to 7 millimeters. You could actually measure with video fluoroscopy, but we have not done any formal measurements. And you can see that it nicely closes where it's supposed to close, and obviously it will result in a good speech post-op. No, frequently they ask me, it's not clear where exactly you are anchoring the flap. Would you show us? This is the marking for the Z-plasty. This is the one how it is cut. This is how it is moved. This is where the flap is flipped over after the donor closure and then sutured to the edge here. Then the next part is that these flaps are sutured to the base of the flap, a couple of stitches, one here, whereas the tip of the Z-plasty is taken to complete the nasal Z this way. So this flap becomes part of the palate. So there is no raw area left. It's becomes a lined flap. This is how it is done. And then on top of it, the muscles, most of the time, this muscle is dissected from the palate. The different I do, a modification, is that this is separated both partly from the oral side and definitely from the nasal side, so that this muscle can move across, and then you suture it on top of this, so that, and to the base of the flap. So it is securely anchored here, reducing the gap between the roof and the upper surface of the palate. There are some examples. This was a 7-year-old girl operated in 2017, a speech sample. This was presented earlier during the demonstration of how to evaluate. And then you can see that there's a small midline gap. This could have probably been closed by just with furlough. And but I went ahead and did a suspension in this patient, and that is the post-op. So that gives a very good closure. So we did an analysis of initial 100 cases. Now it's close to 600 cases I have done in last 6 years. So about 100 cases a year. These cases are done in 2014 and maybe part of 15. So out of which there is near normal in 70 cases and mild abnormalities in 20 and moderate. Moderate includes suspected VPD cases. On this data, I can say that 95% of them are presumed to have a velopharyngeal competence, whereas 40% of them have a persistent compensatory errors requiring speech therapy. The reason for this, after 4 years, is very few of our patients, maybe less than 10 to 20%, only come back for speech therapy. They go back to various villages in distant part of our country. And then when they come back, if they do not, what I have noticed is if they do not have compensatory errors with severe glottal stops, they usually tend to correct by themselves. So you don't, the speech therapy, when it's not possible, you bank on the teachers to be the therapists. The younger the patient, better is the result as can be expected. Now, Chen's pharyngoplasty, this was demonstrated by Philip Chen to us, courtesy Dr. Adenwala at Thrissur some time back. This changed our outlook on how we go about doing pharyngoplasties. And this is a real save situation in case of very severely scarred palates. We can't really do a Z-plasty in the scarred palate because there is not enough tissue in the posterior pharyngeal wall. So, I'm sorry, on the palatal surface of the palate. So you need to augment it. You need to lengthen the soft palate by adding tissue. And you cannot do a Z-plasty because tissue is not there. In this case, in comparison to a Furlow's type of procedure, the palate is cut across on the nasal side. I'm only indicating the nasal half of the palate. Imagine the oral Z-plasty is as usual, has been lifted. And then we cut this. And then it opens up like a diamond-shaped defect and the muscles move towards the palate. And then we take the 2/3 of the width of the posterior pharyngeal wall as a flap. And this is flipped over and sutured to the edge of the palate here. In principle, all this becomes part of the nasal lining of the soft palate. The small part of the palate that is remaining, even in a badly scarred palate, goes here posteriorly, and then they are sutured together. It also is possible, just because they have completely been released, this is from the edge of the hard palate, few millimeters is left, and then it's cut across. And eustachian orifice, you could imagine somewhere here. So the muscle goes below the eustachian orifice level, and this is sutured together. This is Chen's. The difference between a suspension palatoplasty, where you do a furlow, but hook it up to the roof of the palate, whereas in Chen's, you use a bigger flap. Even then, it's only 2/3 of the width of the posterior pharyngeal wall. It is sufficient to line this. It stretches to fill this diamond-shaped defect. And the oral Z-plasty is done as usual. I'll give one example done at the workshop. This is a 5-year-old with, again, poor speech. Video fluoroscopy shows very poor movement of the soft palate. And you look at the Robert Mann has taught us. So this area becomes the pedicle. And from here you can take as much of a flap as required. In this case you don't require much of a flap. Still I will take a bigger flap than what is required, like this. This is a pedicle. This will be twisted and then inset.
Mukul,
Sir,
would a Paget flap would sit better? A Paget buckle flap?
maybe. But I'm so used to you doing this buckle myomucosal. I tend to use it for everything. You can divide this bridge and make a small triangle. Even that will work. I have done it on occasion.
It goes parallel to the gum margin. This way, not this way. Yeah. That was the original buckle flap, which Murali Mukherjee turned. The direction is different.
Direction is from the retromolar area parallel to parallel incisions going through the buccinator. The plane is bloodless below the buccinator.
Here again, you don't use the scissor.
No, sir. Everything is with knife. The correct plane, the patch pad usually is seen. Sometimes it prolapses. You take a stitch to put it back. Or even if it prolapses, as it heals, it gets pulled in. Sister is holding the. You can go right up to this where I am marked. So that this sits here without any tension. As a suture, we can actually lengthen this if it is required.
That's the, actually, if you notice, it takes only a few minutes to raise the flap.
Treatment protocol, then we break for lunch before we take the next section.
We've got one more there.
Sir?
That's the end of the procedure with the flap nicely inset. The 6 months follow-up is not very encouraging. We'll have to wait for a longer time before you can see this. I'll give you another example. One of the most severe I have seen where the
66, 67,
this is the same patient.
67, 8, 69, 69, 70, 90, 91, 91, 91, 92.
This was recorded because they don't usually come back. So now with the cell phone, we are able to record. He still have articulation errors. So I would usually give more time if they are not going for speech therapy. But in small children, he was 5 years old. So it will improve with this procedure. This is a severe case. This is pre-op. Big gap, hardly any movement. This is post-op. You see, this is the width of the even though pedicle has become narrow, this is the width of the flap which was used. That comes to the end of the presentation. Of the cases which I have analyzed, both Chen's and suspension palatoplasty, they very rarely complain of any respiratory problems. Specifically, we are asked about sleep apneas or snoring. Snoring has been a problem in 5 to 10% of the cases. It spontaneously improves in about 6 months to 1 year of time. long term, I have not done a formal speech study or by recording, etc. But we specifically ask them whether they have any problem with sleeping. When they get up in the morning, do they feel tired, etc. And very rarely they have come out with any problems. The problem with majority of them is when the older you operate, the more the obligatory errors persist. And this is the situation where a team effort is probably the most important. Therefore, I have always said that we should be able to do the palettes properly for the primary cases so that you can avoid struggling with these secondary cases as they grow older. The cutoff age, is there a age where the results tend to fall dramatically? I would think about 18 years and above, the results are not that great. But I have seen normal speech. For example, last case I showed, she was 18 years old or older, 19 or so, when I operated. After that, she got employed, she got married, etc. So if an old individual, even about 20, who is doing a job, if he comes to me and asks, what are the chances of me getting normal speech? I say, tell them, there is a chance. I can show you examples, one or two, but you have to work at it much more than a younger person. By doing this procedure, either suspension or CHENS, what happens is the palate is spaced so close, the effort the palate has to make reduces. So like a blink of an eye, it tends to close much easier. So the patients tend to learn to use the palate much better. Thank you.
Thank you, Dr. Mukund. There's a question for you. Are the pharyngeal flaps superiorly or inferiorly based?
They are based on the adenoids. They cannot be inferiorly based. So they are superiorly based.
Savita, can I ask a question?
Yes, Dr. Krishnamurthy, definitely.
Sir, as usual, wonderful presentation. What I want to know is, when do you really decide between a suspension and a CHENS? And do you think there's a big difference? I understand all the differences in technique, but is there a big difference in your results as you have noticed it?
Results are approximately same. In the sense, what we want is velopharyngeal closure. From surgeon's point of view, you can say this is no longer our problem, Savita, this is your problem. So with this, both CHENS and then with the suspension, but it is not 100%. I was hoping that I would say 100% of the time we can correct. But then with suspension also, I had a few cases. For example, 100 cases consecutive. When I started analyzing, 100 cases they have come, those who have come for follow-up, I have found that 3 of them had suspected VPD. At least one of them had a little port which is not closing at all. I can't give the reason, but he was 23 years old. So,
but your first to-go flap is the suspension, right, sir?
Yes. CHENS I would use less than 10% of the time. Even in CHENS, I would do a furloughs type of muscle. If it doesn't come, there are cases the scar is so bad, unbelievable. I did some abroad as well, where the palate hardly soft tissue is a few millimeters in size. There you cannot do a bugplasty. So you just take it and suture it to the lateral edge of the flap. So the flap becomes part of the soft palate in CHENS. The difference between CHENS and suspension.
Right, sir. Thank you.
While we wait for questions, there's one question that has been asked for Dr. Krishnamurthy. How often do you encounter anterior vertebral artery?
While doing furloughs, palatoplasty.
Yes.
I don't think I've seen it. Sir, do you want to take that question? Mukund, sir?
Yeah. So when you're doing the pharyngeal flaps, this even Dr. Adinwala, whose voice you could see as I was doing you could hear as I was doing the MM flap, he asked me, do you do routinely a Doppler study when you're doing a pharyngeal flap? I don't do a Doppler study. We usually try to see if there is a pulsation. If there is a pulsation, we try to palpate. but it's suspension because you take a very narrow flap. There is a midline vessel which bleeds, which may need to be cauterized. But the vessel is quite small. It's never been a big vessel. So midline vertebral artery giving problem, you have to be wary about pulsations in the posterior pharyngeal wall. If you see one, you have to be careful. That's it. I have never seen a big vessel. It never was a problem for me.
Okay.
Thousands of cases, I have not seen a vessel which bled so much that I was in panic. No.
Yeah. There's another question for you, Dr. Mukund Reddy. Where do you put the buccal flap?
Buccal flap is something which can line the nasal surface, oral surface. Wherever you are short of tissue, buccal flaps comes in handy. When you are doing a pharyngeal flap, because it nasal side, the pharyngeal flap covers it. So the musculomucosal flap is always used on the oral surface. If you are not doing a pharyngeal flap, then the buccal flap is usually for the nasal lining, because you want to lengthen the palate and give that lever arm enough of play for it to close. I did a series of using only buccal flaps along with giving an incision as I've shown for chins, where you take the muzzle further down and suture it, sometimes double-breasted, then put a buccal flap on the nasal side. The results from straight line closure has improved quite substantially to about 60 to 70%. But then the rest, other 30%, it doesn't close. What happens is it adds bulk to the flap, the palate, so the palate hangs down into the mouth a little bit in about 30% of the patients. In trying to correct this, I stumbled upon this suspension method, which seems to improve the results up to 90% now in my hands. It has been tried by others. They tell me it's working reasonably all right, but the numbers are less, and then time will tell.
Yeah, and this is another question that has come up. I think it has already been addressed, but if you could highlight it quickly once again. What is the upper age limit for VPD surgeries?
There's no age limit. I have had patients at 37 years of age. One lady, it's not VPD strictly, it was unoperated palate. She developed normal speech. So if 37 has a normal speech, then I would not say any age is a criteria. Criteria is in the mind of the patient.
Yeah, and what is the difference between Chen and original buccal flap?
Buccal flap is used on the palate. It never goes into the pharynx. Chen's pharyngoplasty is a superior modification of a superiorly based pharyngoplasty. It is actually superiorly based pharyngeal flap, which is placed much higher, which is narrower and more physiological, because you are also doing sort of a furloughs and a muscle tightening at the same time.
And the last question before we go ahead with Dr. Karun's presentation, have you ever done 2 buccal flaps for lengthening? If so, what would be the results like?
Yeah, I had done, earlier I said when I was doing a series, then I used to do sometimes both oral and one flap for the lengthening the nasal side, one for the oral side. The results are like this. It will give you a good result up to 60% of the cases. If you want to go beyond that, your palate has to be placed so that it has a less effort to move upwards and close the nasopharynx securely.
And
one or two flap is need-based. It depends on amount of tissue you need for lengthening the oral side and the nasal side.
And is there any criteria to decide on when to go for Shen versus when to go for suspension pharyngoplasty?
So I would start with suspension. I would give a oral incision, lift the flaps, and then see if it is so badly scarred, I cannot dissect the flaps. 1 or 2 patients have been sent to one of my students who said, I am not able to find a plane, please do something. So there, you can only divide the palate and let it fall back. In that case, it is Chen's. See, the worst of the cases, you do end up doing Chen's pharyngoplasty because you provide a lot more tissue for lengthening the soft palate.
Savita.
Thank you, Dr.
Savita.
Mukund. Yes, Dr.
Savita,
Krishnamurthy. Yes.
Dr. Narayanan might have a response for that one, the Shens. Dr. Narayanan. Later?
Sir, can we take that later towards the end?
Okay, that's fine.
Yes.
Oh, yeah, there you are. Yes, you may go ahead, Dr. Narayan.
Okay, no, I was muted. That's why. No, the thing is that in our center we have only, sir has only done the Chen type. We have not done the suspension type at our center. And the thing is that the difference I see between these two, the Chen is more lined than the suspension, but when there is a very large gap between the palate and the pharyngeal wall, it may be very difficult to bring the flap all the way to the apex in the Chen type, whereas it's easier in the suspension type because it's placed more distally. That's it. But less of it will probably be lined compared to the Chen. This is the difference, but we have no comparison between the two.
Okay. Fine. Thank you. Thank you very much for all the things. I know there are more questions coming up. We will take them after this presentation. So please keep posting your questions. We will accumulate them and take them towards the end. Thank you all for your active participation with loads of questions. It really keeps the webinar interesting. May I now request Dr. Karun Agrawal to please go ahead with his presentation on other pharyngoplasty techniques.
So now the platform is ready with the very good discussion on variety of modifications and procedures on furloughs. Basically, workhorse for VPD as for today, as Dr. Mukund and Dr. Krishnamurthy have talked about, is furloughs palatoplasty. But as I discussed earlier in my initial presentation at the time of introduction, that there are situations where when we see the endoscopic pictures and when we analyze them, and based on the criteria which we had laid down, probably there is a need of some more techniques to be there in your armamentarium. And since I am endoscopist, I do endoscopy for all my VPD cases after 5-6 years of age for all the plastic children. I tend to use different techniques in different situations. And if I talk about the statistics, I use exclusive furloughs in 60% of patients. However, I use the sphincter pharyngoplasty in 20% of them and flap only in 10%. And I do not do augmentation. And buccal flap procedure with or without furloughs is almost 10% of patients. So I use different techniques in different given situation. So I like to talk about some of the other techniques other than the furloughs for the benefit of the audience here. Now, what are the other techniques which we should know of? I do not say that one should master all the techniques, but one should know of all these techniques are there in the armamentarium, and sometimes you will definitely find a place where these will be indicated. First is the dynamic sphincter pharyngoplasty. I am very fond of this procedure whenever it is indicated. This is basically a modified Heinz pharyngoplasty, which was popularized by, modified by Dr. I.T. Jackson by using the posterior tonsillar pillar incorporating palatopharyngeus, which gives the dynamism to this flap. And this is, these two flaps are transferred to posterior pharyngeal wall on horizontal incision. And one have to raise inferiorly based flap to create a space for inserting these posterior pillar flaps. This effectively, because the posterior tonsillar pillars are horizontalized and put in the posterior pharyngeal wall, it narrows the lateral gap. That's why in coronal closure, when there is a less movement of lateral wall, this is indicated. So it brings medially the lateral wall. Second, it augments the posterior pharyngeal wall with the muscle and the mucosa which we are transferring. And third, probably it gives dynamism to the lateral wall. I'm not really sure how much movement it gives, but it looks as if some extent it gives dynamism to the lateral pharyngeal wall and helps to some extent in closure. Now, it's very difficult to take a video and picture of this particular technique because it is inside the pharynx and covered with palate and hands and instruments. So it's better depicted diagrammatically. These are the posterior pharyngeal wall flaps, which are, you can say, anteriorly based, which are based on the soft palate posterior margin. And it is divided lower down, and we take the palatopharyngeals, which are there in this. And in this type of surgery, you have to be very careful about the velocardiofacial syndrome, in which the lateral wall may be pulsatile because of the presence of internal carotid artery closer to the posterior pharyngeal, the tonsillar pillar and the posterior tonsillar pillar. In those cases, when pulsation is there, one has to be very careful about this technique. And we raise this flap, these are raised there, and this is the inferiorly based flap, and this gap is created on the posterior pharyngeal wall in the region of the nasopharynx higher up, and these are double breasted. And again, this is tailor-made. One can tighten. If gap is more, you can tighten in double breast. If gap is less, you can suture to end these flaps so that there is not much movement of the these flaps, and you will have enough gap in the center. Let us see one case how it.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Now this is
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
But it is bringing the lateral pharyngeal wall medially so that it is helping in closure. Here again, the speech is not ideal, it is not normal, but there is a significant improvement, and the closure, we can see the physical closure is definitely there, and the mobility of the palate as well as lateral pharyngeal wall are perceptible. So this is one of the example of dynamic sphincter pharyngoplasty. Another advantage of this dynamic sphincter pharyngoplasty is, I can say it is non-physiological because it is making a small partition in the nasopharynx. It is indicated when it is circular closure or coronal closure or very deep pharyngeal gap is there. It gives dynamism, as I said, and it can be tailored as per the requirement. What I mean by tailoring is, this is a case of oblique cleft palate, in which you can see when the patient is speaking, the uvula is getting deviated on one side and there is a gap on the left side. This will give unequal closure. When the coronal closure is there, this part is closing, but this part is not closing during speech. So if we want to do the pharyngoplasty only for this part, I can do one side pharyngoplasty or one side sphincter pharyngoplasty to help in closure of this. So this, I call it as tailor-made. Tailoring is possible in sphincter pharyngoplasty. And second, depending upon the gap, you can double breast or you can suture edge to edge. So that is one technique which we should have in our armamentarium. Second technique which is there in our armamentarium is superiorly based pharyngeal flap, which Dr. Mukund Reddy has very well demonstrated while showing the Chen's pharyngoplasty, and this is almost same. And this has got many modifications by different surgeons. It can be fish mouth, mainly on the insetting of the flap is modified by different surgeons. And one has to suture to the nasal lining, other can suture to the midline along with the levator, or it can be fish mouth in which the soft palate can be split. Fourth is where we can make a sling of the flap and then it can be sutured from the oral to the nasal line. So many modifications are there. And this is port control pharyngoplasty, in which you put the tube on both sides of the flap and then you create 2 tunnels on both sides. And this flap procedure can also be performed with or without palatal surgery, or it can be done along with the furloughs, or it can be done with the intervelar veloplasty as the preference of the surgeon or as it is indicated. When you do the lined one, then it remains like a robust flap as we see on the table. When it is not lined, then it becomes like a string in due course of time because it contracts and it becomes very narrow. This is unlined flap, which I used to do in 90s, 20 years back. And now whenever I do the lined flap. When it remains, what we see on the table, almost similar kind of thing is remained, and you see ports on two sides. This is a, so these are containing muscle. Superior constrictor is included in this flap, but they are not dynamic because the dynamism is lost because the nerve supply of this muscle doesn't remain intact because we are cutting vertically and these fibers are horizontally placed. So it plays basically as obstruction. So it is non-physiological, we always call. And this, there is a risk of sleep apnea. Fortunately, Dr. Mukund Reddy has not come across, it's a great thing. But I have come across a couple of patients where sleep apnea was there. In one, we had to divide the flap only because it was not improving even after 8 months or 9 months of follow-up. So this is, we can see how 2, 3, 4, 5, 6, 6. So basically, flap is not moving. It's basically it is working like obstruction in the middle, and palate is moving and trying to close the gap on two sides. This is he saying, but it is almost closing because you can see the air bubble forming there. So that is about the superiorly based pharyngeal flap pharyngoplasty. Third one which one will like to know about is the buccal myomucosal flap, which we had already discussed during the discussion. It has been answered by Dr. Mukund Reddy and it has been presented. This was introduced by Indian surgeon Dr. Mukherjee from Kolkata in 1969. It was popularized quite a lot by Dr. Jackson. I learned from Dr. Jackson how to use it and different variety of buccal myomucosal flap. He is the one who said it is myomucosal flap. Dr. Mukherjee said it is mucosal, it is cheek flap, mucosal flap. But now it is being popularized by Dr. Robert Mann. He demonstrated in Fitur during one of the workshops a couple of years back. And we learned a lot, different variety of its indications and its utilization. This diagram is from Dr. Mukherjee's presentation where both side flap has been used as it was asked by one of the delegate here. And you can see the gap is created and one can close the, while doing the palatoplasty for the dehiscence, we can perform the buccal myomucosal flap if there is a very short palate, and it helps in functional outcome. Fourth one is the augmentation pharyngoplasty. This is a very funny pharyngoplasty technique. It comes and goes every 5 years. And whenever it comes with a new material being used inside the pharyngeal wall. We have seen the Teflon, we have seen the silicone, we have seen so many material. But now for past 5 years, people are popularizing the fat graft, and cartilage was the previous one. I do not have much of, I do not have any experience of augmentation pharyngoplasty in VPD because I don't think it is predictable and it is right to use the fat in the place where fat doesn't exist normally. And it is likely to get absorbed from the posterior pharyngeal wall if it is injected. And that is true in long term. Whatever papers have come, they have said that augmentation pharyngoplasty, when fat is used, it doesn't exist there. Now, lately, there are a couple of papers on use of alloderm in the posterior pharyngeal wall by some of the surgeons. I do not know what is the outcome, but this can be used in cases where only 2 to 3 millimeter gap is there, and especially when it is a coronal closure is there. One can know about this technique and keep in the armamentarium, but I do not have much experience. I can't vouch for this technique. This is the fat augmentation, which I took from a journal, Indian Journal of Plastic Surgery. And alternatively, one can use the costal cartilage there, which needs to be fixed in that interoccipital joint. Lastly, the group of material which we should know about is the prosthetic options. These are the options which we, as surgeon, we do not vouch for, or we do not prefer, we do not popularize, we do not know about it. Palatal lift devices and speech bulb, and even the pharyngeal obturators. But I was very surprised when I went for one of the conferences and workshop in Japan, and then I realized that majority of the patients who are waiting for VPD correction, surgical or the assessment, after 5 years, majority of these children are being supported by palatal lift devices in that country, and Even in Korea, I have come across the surgeon who says that they use quite often these devices. I do not have any experience. This pictures are from Mysore, All India Institute of, this is given by Dr. Pushpawati to me for publication, and this I have presented here only for the information. This doesn't belong to my lab or my armamentarium. So these are the variety of procedures and material which are available for us to know to manage the VPD whenever there is opportunity or wherever there is. But as surgeon, we all know that whatever we do in VPD, whenever it is established, there is, in spite of all this knowledge of armamentarium, knowledge of furloughs and so many modifications and so many addition and subtraction of the techniques by various surgeons, we are not able to manage and reach to normalcy in all of them. So best is why to give a situation where it should occur. There is no substitute for good primary surgery in the palate. If we are able to do a complication-free palatoplasty at right time, now we are seeing almost all the children, even in India, most of them are coming below 6 months of age. And if we are able to provide this surgery and at first attempt we do the right job, then probably the incidence of VPD will be less, and we will tax the SLPs like Dr. Savita much lesser and lesser in giving them services. So first attempt is the best attempt, and there is no substitute to good primary surgery. Every surgical correction which we have talked about, furloughs or whatever techniques are there, we have to supplement with the speech therapy in VPD cases, assessment as well as therapy. Thank you so much, and I hand over the slides, the forum to Dr. Savita.
Thank you, Dr. Karun. Can you quickly explain what's the difference between the superior-based pharyngeal flap that you described with versus the suspension pharyngoplasty that was discussed by Dr. Mukund?
See, suspension pharyngoplasty is a very narrow flap, which is 1 to 2 centimeter in the region of the adenoid. It is only a short flap of 2 centimeter, which is inserted over the soft palate in the middle after the furloughs palatoplasty is done. What I am presenting, the superior base pharyngeal flap is a large flap where we take 2/3 to 3/4 of the posterior pharyngeal wall, and the length is almost like 6 centimeter, 5 to 6 centimeter long. And this is turned over and sutured to the nasal lining. And the muscle of the superior constrictor is hitched to the levator so that it gives better insertion. And the posterior pharyngeal wall is closed primarily, and two sides of this flap needs to be controlled. In suspension, you don't need to control the aperture on two sides of the flap, but in superior base pharyngeal flap, you need to manage the port on two sides so that you have got adequate port for the breathing to be there, the air to come out through the sphincter. That's why this is a difference. The suspension has got very small flap and large gap on two sides. In superiorly based pharyngeal flap, you have got a large flap and a small gap on two sides.
Thank you, Dr. Karun. Another interesting question. So if there is a patient who does not improve with obturator, can we say he will not improve with a pharyngeal flap also, because both of these almost refer to the same?
Not really. Actually, the obturator gives only the closure of the pharynx, the pharyngeal closure it gives, but it does not give any dynamism to the palate. So we need to assess these patients. Even if obturation doesn't help, we need to assess these patients with the instrumentation, and based on the instrumentation objectivity, we have to decide which flap will be useful and which will not be useful. As such, the pharyngeal flap is not a very good flap, a very good procedure for majority of these VPD cases, because that is obstructing. It's a non-physiological procedure, and it has got its own complications and problems. That's why it has to be used only in a small group of patients where we have got sagittal closure and deep closure, where we are not able to bring the palate behind. There only it can be used, otherwise it does not have much role to play in VPD surgery independently. it has got role along with the furloughs or the palatal surgery. It is a supportive measure, but not independently. I do not think independently it has got great role in pharyngoplasty.
Thank you, Dr. Karun, for that clarification.
Thank you.
So we will now go ahead with the next section of the webinar for today, which is looking at airway management post pharyngoplasty. May I request Dr. Baljit to please address this?
Good afternoon, friends, and greetings to all the people, all the participants who are from other countries. After some very interesting presentations by our surgical colleagues with excellent videos, we'll talk something that's related to the anesthesia. And when it's anesthesia, the core issue for any anesthetist is the airway management. I will not go into these things. Let's have a look at what is the age structure of the patients. So in this large study, what we have seen is that the age structure of most of the patients, more than half the patients is between 4 to 7 years, and the next age group is 7 to 10 years. So we are dealing with patients who are between 4 to about 10 years of age. This has significance because these children are more easily managed with regard to the airway as compared to the children who are, say, less than 1 year or around that age. The prime concerns in the postoperative period are of airway, bleeding, pain management, and the age of the patient, which specifically relates to the fluid management as well as to the temperature. But here, we'll be dealing only with the airway management rather than the bleeding and other issues. Now, when we talk about airway management, whenever we are taking up such patients where there is a possibility of airway compromise, it's always good to have the airway trolley, difficult airway trolley in readiness, where all the gadgets that you need, the laryngoscopes, different sizes of airways, nasopharyngeal airways, different kind of size of blades, and the magnetic forceps, and all those things which are required should be there. The fiber optic bronchoscope if you have, video laryngoscope if you have. So that would, that would be a good help. Now let's come down to a scenario of a case. Say a patient was shifted to the postoperative area, and 15 minutes later, he was found to have difficulty in breathing. There were some inspiratory sounds when he was breathing in. The breathing is labored. Patient is struggling to breathe and is in visible distress. Bag and mask ventilation was started, but wasn't successful. Now, there can be certain scenarios. Scenario one is the easy bag and mask ventilation. When I say easy bag and mask, that means easy ventilation with the ambu bag and difficult laryngoscopy, direct laryngoscopy. So you can ventilate that patient very well, but on performing laryngoscopy, you don't see the vocal cords well. Now, in this case, it is somewhat better, somewhat more comforting because the patient can be ventilated with bag and mask. So at least the oxygenation of the patient would not be under compromise. Now, in case the laryngoscopy is found to be difficult, you can't see the vocal cords, it's always a good idea to reposition the patient, put a roll under the shoulders, and then consider indirect techniques like video laryngoscopy and fiber optic bronchoscopy sooner than later. And limit the number of unsuccessful attempts to a maximum of 2, because more the number of attempts that you do to secure the airway, it increases the possibility of serious complications later on, causes more of bleeding, and that makes the matters worse. And consider using airway adjuncts such as a bougie and even ultrasound. When you're talking about ultrasound, attempt to use ultrasound only in case you are well versed in. But if you want to use it, just because the device is there, but you're not familiar with it, I think this is not the situation where you should try your hand at this. And if still unsuccessful, tracheal intubation, with the tracheal intubation, place supraglottic airway device and continue the same algorithm for the post supraglottic airway placement. Now I have dimmed this sentence a bit because supraglottic airway device in a patient who has just undergone surgery would not be a great idea because it is going to create problem with the surgical closure. So I've just put this somewhat behind. Scenario 2, you have a difficult bag and mask ventilation. Now this is more difficult because here you will have difficulty ventilating that patient. When we say ventilating the patient, that means we have difficulty in oxygenating the patient. The saturation is going to drop and that can create a serious problem. Here again, look at the patient's position, optimize that, use two hands, 2% technique. When I say two hands to be used to hold the mask and ask your colleague or some assistant to perform ventilation with the bag, in his hand, gradual ventilation, small tidal volume ventilation. It's a good idea to think of schooling to facilitate ventilation and intubation in these cases. And this is a better option, better choice, because in case the difficult bag and mask ventilation is due to laryngospasm, the use of muscle relaxant would break that laryngospasm and you can intubate that patient. But when you're doing two hands, 2% technique, ensure that there's no gastric distension, because in case there is gastric distension, there'll be less room for the lungs to expand and the patient will have a respiratory issue. The next line is insert a nasopharyngeal airway. Well, to insert the nasopharyngeal airway at this stage, again, may compromise on the surgical closure. And it's a good idea to ask the surgeon to place a nasopharyngeal airway before he comes out. I think that's a better option than to insert nasopharyngeal airway when the airway is under compromise and the patient may be somewhat bleeding. The third situation is still worse. You cannot intubate that patient and you cannot ventilate as well. Now, this is a real challenge for any anesthesiologist. Here, the option that you have is consider rigid bronchoscopy or the surgical access is next. If you don't have rigid bronchoscope, call an ENT specialist and there is hardly any time to wait. Perform needle cricothyrotomy as a first option for the front of neck access if the surgeon, ENT surgeon is not immediately available. And while you're doing all this, passive oxygenation should be continued with the nasal cannula. When I say passive oxygenation, what it means is that you continue to oxygenate that patient with the nasal cannula, even if the respiration is compromised, because this would lead to some mode of oxygenation, to the patient, and it will buy you some time. The option here in such a scenario where you cannot intubate and where you cannot oxygenate also, one option is cannula cricothyrotomy. It's very difficult to practice this kind of rare event, and the simulators can't replicate the real pediatric airway. And it's been seen that in a situation of confusion in the postoperative period when the airway is compromised, there is a very high failure rate of up to 60% even in adults. And the incidence is higher in children because the airway is narrow and there is some amount of fat in the front of neck. There is also a real possibility of damage to the posterior tracheal wall with the needle, and of course it can go through the posterior tracheal wall even to the esophagus. And in one study it was seen that 22 out of 30 could not cannulate the trachea within 4 minutes of an 8 kilogram piglet model. So you can understand how difficult it is. One has to be real expert when it comes to this. But the good habit it's a good habit to feel the cricothyroid membrane preoperatively just in case. You never know when such a situation occurs. So if under anesthesia, you just put your hand there and you would identify that this is the area where the cricothyroid membrane is, so that you, just in case you need it, you know where exactly it would be and what's about the size of the cricothyroid membrane. In neonate cadavers, the cricothyroid membrane has a mean vertical dimension of 2.6 millimeter and width of 3 millimeter. And in adults, the mean width is 13.7 millimeters and the vertical dimension is 9 to 19 millimeter. In the newborn, this cricothyroid membrane is angulated to 60 to 70 degrees, but it becomes nearly vertical about 5 to 6 years. So that makes it somewhat easy, because in case it is angulated, then from a wider area you suddenly enter the narrow area, and when you put a needle there, the risk to the posterior tracheal wall, the damage to the posterior tracheal wall is quite real. And that was the reason we looked at the age structure of the patients who presented with these difficulties. Then the unanticipated difficult airway, children become hypoxic and bradycardic very soon, may lead to cardiac arrest more rapidly. If we continue to provide passive oxygenation during all these periods of airway management, especially during apneic episodes, well, you can buy some more time and use a nasal cannula for this or any other device which would reduce the desaturation and the need for repeated attempts. Direct laryngoscopy is the most common initial technique. More than 2 attempts at this has a high failure rate and can lead to severe complications subsequently. And if it is unsuccessful, change to an indirect technique, which I told earlier, video laryngoscopy or fiber optic sooner than later. Paraglossal or the retromolar technique is another that can be considered for the micrognathic child. This technique avoids the tongue and it lifts the epiglottis from the side of the mouth. And this may be helpful, to visualize the cords more easily. Video laryngoscopy improves the glottic views significantly, and it may have limitation in case of trauma due to previous attempts or bleeding in the postoperative period. And the tracheal tube insertion may be difficult despite good glottic view. Long time for successful intubation across various video laryngoscopes is seen, and the rotation of the tube, external laryngeal manipulation and stillet are sometimes helpful to direct the tube towards the vocal cords. Supraglottic airway devices is not a good choice here, although I have mentioned it here, but why it is not a good choice? Because these devices have a large cuff, which will go into the oropharynx, and that's the area of the surgery, and it is going to disrupt the surgical closure. So that way, it's not a good choice when it comes to management of the airway in these kind of surgery. Although I have come across 2 anecdotal case reports, where as a last ditch effort, the anesthesiologist was not very comfortable with the needle cricothyrotomy. So what he did was he pushed in supraglottic airway device because he was not able to ventilate that patient and he was not even able to oxygenate. So he could buy some more time because with the help of supraglottic airway device, he was able to ventilate that patient, oxygenation improved, and then the ENT surgeon was called for and tracheostomy was performed in such cases. So these are again devices which can help you in very desperate situations. Optical stillet is a malleable fiber optic stillet with the distal eyepiece that can be connected to the video or can be used on its own, and it combines the features of fiber optic bronchoscope and the light band. It has a short learning curve unlike the fiber optic bronchoscope, and it can accommodate tubes which are as small as 2.5 millimeter internal diameter of the tracheal tube, and like bronchoscope, the lens can easily get obscured with secretion and blood, and this may render this device useless. It's rigid also, and it can not be passed beyond the vocal cords. This is what it looks like, and it can go up to the vocal cords up to this much area, and thereafter when you try to push the tracheal tube over the scope, well, the tip of the tube can strike the anterior tracheal wall and may refuse to go in even though it is correctly inside the trachea. But well, if you use it more often, you can devise your own techniques or maneuvers with which you can push the tube inside. Now, flexible fiber optic bronchoscope is a gold standard of difficult airway in any situation. But it has a big limitation in a surgery like this because there may be some amount of blood and secretions over there at a time in the postoperative period, and the presence of blood will make it difficult because any amount of blood, even a small amount of blood there at the tip, will make everything look red and you can't see anything. And to make it a viable option in the pediatric patient airway, the provider must be proficient. Now, having proficiency of its use in adults is one thing, and one should not think that familiarity in adults would equate to the proficiency in children also, because children are a different thing altogether. And in case you haven't used this before, this is not the situation for use as a first attempt ever in such a scenario. The next option that you have is the front of neck access. Some procedures of this kind and includes all needle and cannula or devices, which are kind of rescue devices, rescue maneuvers in such cases. it may be a desperate attempt to secure the airway, particularly in cannot intubate and cannot oxygenate situation. It's a good thing to have an ENT surgeon to perform tracheostomy, but in case the ENT surgeon is not there, you are left with no choice in a situation of cannot oxygenate patient, but to try, needle cricothyrotomy. Although cricothyrotomy is recommended for adults, evidence is low for recommendation in small children. But the question is, what next? Size of the cricothyroid membrane is much smaller as compared to adults, and that's what makes things difficult. This is the way the needle cricothyrotomy is performed. You have the cricothyroid membrane over there, put the cannula along with the needle inside. The moment you aspirate air here in the saline, which is loaded in the syringe, stabilize the needle and push the cannula over it. It will go into the trachea. You can oxygenate the patient with this, but you cannot remove carbon dioxide unless you have some sort of jet ventilation, and even then you can't have much time. The moment you put this in, it's you got to have the ENT surgeon who would perform a good surgical tracheostomy in such cases. Now, all the bodies like Difficult Airway Society, All India Difficult Airway Association recommend a cricothyrotomy as the first front of neck technique if ENT surgeon is not available. This is a big thing. If ENT surgeon is not available. Here in this case, there is no scalpel incision which is given, and the membrane is palpated, the cannula is inserted till its air is aspirated, and the sheath is pushed over the needle, which is then pulled out. And the cannula is then connected, as I told you earlier. This is not a substitute for tracheostomy. Now, this is the kind of algorithm. Difficult laryngoscopy have maximum number of 2 tries and provide 100% oxygen, maintain adequate depth of anesthesia or sedation for the patient, and call for help, ask for difficult airway trolley. And try bag and mask ventilation in case it is, if you cannot succeed, reposition the head, oxygenate and ventilate with 4 hands, in the sense 2 hands to hold the mask, 2 hands to ventilate. And in case you succeed in ventilating the patient, take a breath, plan your next strategy, and then have another attempt at intubation with some help available. Now, in a situation of impossible intubation and oxygenation in a patient, you continue to administer 100% oxygen. This is the same what I told you initially was the passive oxygenation, using 100% oxygen, optimize head position again. And if you still are not able to oxygenate, then you are left with one, of course, you should call for ENT help even before. If it is available, ENT surgeon comes in from the next OP, you go ahead with the emergency tracheostomy, or with the rigid bronchoscopy, and then get ventilation, and you can plan what next is to be done. In case the ENT surgeon is not available, then of course the needle cricothyrotomy remains the only option. Well, the take-home points are that airway compromise in post-operative situation is not uncommon. However, I must say that in a situation like this, where the patient has been shifted after surgery, the possibility of such a situation where you come down to tracheostomy or the needle cricothyrotomy is much less, because the patient has undergone surgery just maybe a short while back, and you have already intubated that patient. The problem in intubating such patients can occur only in case there is bleeding and you cannot visualize the glottis properly, and you cannot also use fiber optic bronchoscope, because once the blood touches the tip of the fiber optic bronchoscope, it becomes, it doesn't help you at all. It is basically the combination of a difficult airway and concomitant bleeding which makes the matter worse. And the complications of serious concern. One is the complete airway obstruction. Next is to failure to oxygenate. This can be disastrous. Airway trauma due to repeated attempts, and fiber optic bronchoscope, as I just told you, may not be of help in the immediate post-operative period because of the presence of blood. So one must have familiarity of front of neck access. It's very important. Surgical access, if ENT surgeon is not readily available, you are left with only needle cricothyrotomy. Well, I would like to say that difficult intubation or ventilation can occur at any time, and you must always be ready. However confident you may be of dealing with any trouble, I think the safer option is to stay out of trouble. Thank you very much, and over to Dr. Savita, please.
Thank you. Thank you very much, Dr. Baljit, for touching upon something that's very essential and crucial as part of safety measures when we're talking of surgical procedures. We will take up any questions relating to this topic towards the end after the next presentation as well.
Sure.
Sure. Yeah, thank you. Thank you very much. Moving forward with the next presentation, which is looking at speech therapy following velopharyngeal correction. Following any surgical intervention, it's very, very essential to look at speech therapy, as has already been pointed out, and the importance of speech therapy has very beautifully been compared with, oiling the machine after a repair. I really like that analogy, Dr. Karun. Thank you for that. So while we say it is essential to go ahead with speech therapy following surgical intervention, the other way is also true. For a successful therapy, it is very important that we have a person with a velopharyngeal port which is capable of functioning. So while we talk of speech therapy, it's very, very important for all of us in the team to remember that speech therapy cannot correct structural defects. It targets only on the function, that is the speech. Adequate structure is essential in order to achieve normal speech. So we need a velopharyngeal port which is capable of functioning so that whatever are the learned error patterns which are inhibiting the velopharyngeal port from functioning can be corrected by the speech therapist. So when is therapy initiated after VP correction or after surgical intervention? Ideally, 4 to 6 weeks after surgery, we can start therapy. In case of older children and adults, we can start off much earlier as well, much before 4 weeks too, if the person is comfortable with the process of speaking. The focus of therapy is slightly different when we are looking at post-VP correction. The main objectives are to reduce the perception of nasal emission and nasal resonance. The nasal resonance part of it is predominantly taken care of through the surgical correction. It is the nasal emission which are accompanying speech sound production, which usually requires correction. And sometimes patients end up having phoneme-specific hypernasality. That is, the hypernasality is persistent only on certain speech sounds and not across all the speech sounds. Those are again the instances where we work on reducing the perception of hypernasality. The next main objective will be to facilitate and generalize oral productions. So this is where the point that we've been discussing throughout the other presentations as well comes up. If a patient has remnant compensatory articulatory errors, it's very, very crucial that they attend speech therapy in order to bring about a complete change in the speech. I know surgeons love speech understandability and speech acceptability. But if speech understandability and acceptability has to improve, these are the parameters that one has to work on in speech therapy. Then the next objective in speech therapy will be to maximize the range of velopharyngeal motion. And this is done again through the process of working on oral productions. We do have evidences to state that once we are able to generalize oral production and facilitate oral production of speech sounds, it automatically improves the range of velopharyngeal motion. And yes, the ultimate objective is to improve speech understandability, but that can only be worked on by touching upon each of these parameters independently. So what are the therapy techniques that we use as speech therapists when we are focusing on therapy post-VP correction is multisensory feedback, that is the gold standard, open mouth approach, and emphasizing on use of appropriate rate and loudness of speech. My most important aspect, or almost 80% of my therapy timing, will be taken up by the first technique, that is the multisensory feedback. So when we're talking of multisensory feedback, it is predominantly used for eliminating the nasal air emissions which are present. And when we are talking of individuals after velopharyngeal dysfunction, after correction of velopharyngeal dysfunction, there may be phoneme-specific nasal air emission. And more significantly, nasal air emissions are going to be perceived on the pressure consonants. So we work on improving the production of the pressure consonants and work on eliminating the nasal air emission by using a range of feedback providing methods. We use low-tech auditory-based methods, low-tech visual-based methods. We can also use the high-end, high-tech methods in order to provide feedback. Most oftentimes in clinical setups, there's a lot of impetus given to the low-tech methods because they are easily accessible. And there are also simple tools available that the patient can modify in his daily environment that he or she can use in order to get that feedback as well. So some of the low-tech auditory-based devices that we use is basically, the rationale is amplify the nasal air emission so that the person is able to appreciate it and use strategies in order to reduce the same. Now, reducing the same, again, that's where I said a proper structure is important. If a person is having a velopharyngeal port which is remaining open throughout, how much ever effort he's going to put, he or she will not be able to close the velopharyngeal port. So when we have a port which is capable of closing, we can use feedback methods by providing sounds without nasal air emission and with nasal air emission, and gradually work on eliminating the emission on those sounds where they are present. So we can use devices like the listening tube, which is just like, you know, the drain duct of a washing machine, basically a tube which can be used with one end at the mouth and the other end at the ear, or one end at the nose and the other end at the ear, so that the nasal air emissions are amplified and they are able to get a feedback of the productions. So we use a lot of interpersonal speech feedback and intrapersonal speech feedback in order to be able to help them reduce these emissions using these devices. This is the oral nasal listener, what you see here, which is basically nothing but two stethoscopes which are connected by means of a connecting tube. So the advantage of the oral nasal listener is both the clinician and the patient can simultaneously hear the speech, and it provides instantaneous feedback about the productions. The other methods are the visual-based methods, where we can use either a dental mirror or a tongue depressor to show the fogging when there is nasal air emission and help them eliminate it. Or we can also use this little device which is called a seascape device, which has a little a thermocol ball or a little thing that fluffs up inside this vertical tube. So while the person speaks, if there is a nasal air emission, the other end is kept towards the nostril. If there is a nasal air emission, there'll be a little ball that fluffs up when there is nasal air emission. So we use this as a feedback and try to help them produce it without those nasal air emissions. There are also high-end devices like the nasometer. I know of clinics which have also used the endoscopy by itself as a feedback providing mechanism. So with the endoscope inside, the person is asked to produce those sounds where there is velopharyngeal closure and the sounds where there is without velopharyngeal closure, and try and appreciate the differences between the two. So all of these are methods of multisensory feedback, predominantly looking at eliminating nasal air emissions and improving oral resonance. We also use, so while hypernasality and nasal air emission is one side that is worked on, the other aspect that is worked on, which is very important, is facilitating speech sound production or facilitating correct articulation. It's important that whatever compensatory patterns are there or whatever mislearned patterns are there, those have to be eliminated. The mislearned patterns in individuals with cleft predominantly results in backing of the productions. So sounds which are supposed to be produced in the anterior part of the oral cavity are backed, and they produce it either at the level of the glottis or at the pharyngeal level, So we work on eliminating those, and there are a wide range of cues that a speech therapist can use in order to eliminate these and facilitate correct oral productions. Just being able to help an individual practice oral productions in the correct manner itself facilitates better velopharyngeal movement. So there are auditory cues, visual cues, phonetic cues, tactile cues, manual and verbal cues that can be used. In some instances, when we have an individual who is not having any oral productions, we sometimes work on this aspect of therapy even before velopharyngeal correction. We do try and facilitate oral productions in them, but one has to keep in mind when there is a suspected velopharyngeal dysfunction, while the person may attempt and learn the placement of the articulator in the anterior part, it is very difficult for them to channelize the airflow in the right direction. So while the placement might move anteriorly, the airflow might still be directed through the nasal cavity in these instances. But what we have generally seen is when they have understood the placement cues before surgery, it becomes easy for them to correct the articulation production after VP correction surgery. So that is one of the things. And while we are working on providing these cues, it is important that the speech therapist or the speech pathologist looks at providing cues for both the placement as well as the airflow. Both of these have to be targeted on if one has to have optimal speech production. So here's a video where we are working on cur production for this patient before VP correction. You can notice that there is a lot of effort that goes in from his end to produce the cur in the correct place. And this is, he's still not, in this particular session, he's still not completely achieved the production, but you can see that the placement is being attempted in the correct production, in the correct place. So you can appreciate that while he's trying to produce the words with the cur, there's still a lot of effort that is going in on the cur. And while he's attempting to move it anteriorly from the glottal position, there are still instances where it goes back into the glottal position. And this needs a lot of work. And what happens is once they have understood the oral placement, in the immediate post-operative period, they are still able to practice the correct placement. And that facilitates better progress in therapy when we work on them after the surgical correction. The other technique that we generally advise and we use is use of open mouth approach and appropriate rate and loudness of speech. Using an open mouth reduces resistance to the oral airflow. So it facilitates oral airflow because of the use of open mouth approach, and ensuring adequate rate and loudness of speech helps in improving the overall understandability of speech. These may not have a direct impact on velopharyngeal functioning, but they help in improving and facilitating generalization into the connected speech. So one cannot work on this as an independent measure, but along with the other measures, and when we work on conversation and connected speech, these are strategies that a speech pathologist can keep in mind. I've put this in bright red. I can make it as bright as needed. This is put in red to indicate that this is not meant to be practiced. Non-speech oromotor exercises such as blowing, sucking, etc. are not recommended for changing speech in individuals with cleft before or after VP correction. The nature of deficits that we see in individuals with cleft lip and palate is very different, which does not require the need for non-speech oromotor exercise. And working on non-speech oromotor exercises will not automatically translate into speech, because we have enough evidences to state that the velopharyngeal movements for non-speech activities and non-speech functions differ from that for speech. There are lots of evidence that have come up, lots of velopharyngeal studies which has shown that the patterns of movement are different. The Smile Train website also has a document which says why non-speech oromotor exercises are not recommended for individuals with cleft lip and palate. Those interested can go through it. So here's just a quick case profile. So this is the sample of a patient before surgery. So this is a patient who has undergone a superior based pharyngeal flap, and this was the immediate post-operative, and this is after 6 months of therapy. Yeah, so appropriate use of therapy techniques will really help in bringing about changes in speech. So for successful therapy, if you ask, these are the 5 major things one has to keep in mind. Make sure you're working with a suitable candidate. When I say a suitable candidate, it is someone who has a velopharyngeal port which is capable of moving. Use appropriate stimuli during speech therapy. Make sure you target the right sounds. Usually it is the pressure consonants that we work on, and even within the pressure consonants, we first work on the voiceless pressure consonants, the stops, then move on to the voiced stops, and then we move forward to the fricatives. So those are the different hierarchy of speech sounds that a speech pathologist would be working with. Ensure that you use accurate techniques. Once again, I emphasize here, no sucking, blowing, and ovomotor exercises. They are not required for cleft speech therapy. Use the correct procedures in terms of transitioning from objectives, use of reinforcement, and above all, effective feedback. I think the crux of a speech therapy lies in this, in how effectively the speech pathologist is able to give feedback and help the patient correct the speech patterns. So with that, thank you. We will take up any questions as they come up.
I was saying that the decision to use suspension or chins is not based on the findings on endoscopy. Both are used for medium to large size gaps, but it is decided by the amount of scarring in the soft palate. If the flaps do not go across, there is not much of lateral wall movement, then I would do a chins. If the palate is supple enough, then I will do a suspension, because once the palate is repositioned in a proper place, it helps even lateral walls and everything to move. So it sort of comes together. If the palate is supple and soft, even if it's short, it doesn't matter. It's basically lateral scarring. In this scenario, I have to say that those cases which have been operated by Sommerlad's technique, there is a lot more lateral scarring because people have gone to the base of skull trying to mobilize the levator. So now I do much less and less of that sort of thing because trying to demonstrate the levator will leave a lot more scarring primarily.
Okay. Sir, there's another question for
Savita?
you regarding the, yes, Dr. Krishnamurthy?
No, after you finish. I have a question for you after you finish.
Sure. There are a set of questions for Dr. Mukund Reddy. We'll finish those and then take up the question in the other thing. Dr. Mukund Reddy, another question for you is, will the flap division be done in buccal flap? If so, when will it be done?
It is usually not required in small children because it goes behind the teeth. In grown-ups, it is required because it comes over the molar, particularly when you're using it on the oral covering, which is usually done. In that case, after 2 weeks, it can be divided anytime after 2 weeks. I tend to divide it if the patient comes back with a complaint that they have pain or some problem. Otherwise, we can leave it.
Okay, thank you. Are the dynamic procedures that you described really dynamic?
The center part, like Karun said, the flap itself only helps to position the palate where it's required. They are dynamic. Proof is in the pudding, like it is said, that how many of them have VP competence. Majority have. That's the proof.
Okay. Do you use Foley's catheter laterally when doing pharyngoplasty?
No.
If yes, how do you decide the size?
No, I don't use any catheter. Occasionally, actually, in small kids who are obligatory nose breathers, like it has been mentioned earlier, I use occasionally a nasopharyngeal airway, but that is only in obligatory nose breathers. I have had only less than 5 patients in my entire thing who are obligatory nose breathers. Then you need a nasopharyngeal airway, irrespective of age. Usually, they tend to be very small children.
Okay. Another very interesting question. Would you recommend that Furlow's palatoplasty can be done routinely as it may have a prophylactic benefit for VPD?
Yes, I do. I do exclusively furloughs nowadays for all my cases, and I have very good results. So I would recommend, why do secondary furloughs when you can do and prevent VPD in more cases? Yes, I do.
Thank you, Dr. Mukund. If there are more questions, I will get back to you. Yes, Dr. Krishnamurthy.
So, Savita, I have one question for you and also an answer for one of the questions about the nasopharyngeal airway. Shall I ask your question first?
Yes, sir.
So, Savita, from what I understand and what I saw even now, some of the times doing the speech therapy is very laborious. I see that children sometimes, when they don't see noticeable difference quickly, give up. Is that your experience, and do you have strategies to overcome that?
Yes, it is laborious. I agree, because we are dealing with behavior. The whole thing is difficult because we are dealing with behavior, and so all aspects of behavior changing applies even for this. And it becomes all the more challenging when we are working with children. It's sometimes much easier to work with adults because they already are motivated learners. I do not have to work on motivating them. So while working with children, one of the important thing is we need to set the objective very clear and have a realistic expectation, which is convinced or which is kind of discussed with the parents. That's the first thing.
Okay.
So the parent has to know that there is no quick fix remedy when it comes to speech.
That's very important.
Yeah, there is definitely no quick fix remedy because they're used to seeing procedures and seeing changes happen overnight. They walk in The child goes into the theater. When the child comes in, he's out with a totally new structure altogether. So speech therapy does not work like that. So the first thing is making them understand that it's not going to be quick fix procedure. Two, another thing that has to be done is we need to lay out the plan very clearly. Tell them that this is the order in which we will be working on. So we will first work only on this particular sound or this categories of sounds. Once we see change in that to this extent, we then move on to the next sound. Then we move forward to the next sound. So this is with respect to keeping my parent motivated to bring the child in for therapy.
Right.
The other aspect is keeping the child motivated. I think keeping the child motivated will automatically happen if therapists work on keeping the therapy sessions engaging for the child.
How do you do that?
Therapy sessions should not be looked at as a process where the child has to come and repeat 100 words after me. That's not the focus in a therapy session. How can I make the child repeat these 100 words in a way that's interesting for the child? How can I make it? So what are the different activities that we can use? So that is why we always emphasize, do not take therapy in the same place where you're doing the assessment, because the assessment is done in a very formal environment. But when I'm working with a child for therapy, especially for children, I need a very casual, informal environment where I can work, where I can incorporate a range of activities. So I may use activities like story reading. So I may create stories which are loaded with the pressure consonants that I'm working on. You may create fun game boards with specific speech sounds that you're working on. So it all depends on how you make the process engaging with the child. So once we are able to engage the child's motivation level improves. Yeah, okay. So yes, Dr. Mukund.
Savita, can I continue with the Krishnamurthy's? He's busy with something else.
Yes.
Yeah, can I take the thread on? Actually,
yes, Dr. Karun.
He is absolutely right in pointing out the difficulty of people getting involved for the long time of the speech therapy as well as the surgical technique, surgical management also. That's why I mentioned that many of the children, when they grow up, they go to professional colleges and they do not want further management because it is quite time intensive and it requires a lot of effort and time, and they have to give a lot of other the doubtful benefits. So I call that as VPD burnout, VPD care burnouts, because these people do not want to have further treatment and they are very happy. They get adjusted very well. So there is another means there are children who are at two ends of the spectrum. One will continue and the others drop out, but they are very communicative. They will not drop out and they will vanish. They will keep communicating, but they will say that I am very happy, sir. I will not like to continue with therapy and I am quite adjusted. So that we have to keep it in mind, and we have to abide by what patients want, what patients desire. That also we have to take into consideration.
Yeah, I completely agree with you. The moment you talk of older children and adults, speech therapy or any intervention for that matter only comes in if they want it. If they do not feel the need to change the speech, I may be the best speech therapist in the world, but I will not be able to bring about changes in the speech.
Absolutely.
For the simple reason we are dealing with behavior. That's all.
Yeah.
The question I wanted to ask you was, this odometer is not recommended, but is it harmful? The reason I ask is, I use it as something to fill the gap so that patients and the parents are occupied, using a straw to drink, use a blowing instrument, etc., so that they will come back, and then I can do an endoscopy to see whether the ports are closing or not before sending to speech therapy. Do you think it is harmful?
Sir, but instead of asking them to spend time drinking with a straw and doing something like that, you can give them speech activities itself. There are specific set of words that can be given for them to practice. And I mean, if you can ask them to practice that, you might as well ask them to practice this, which will have an impact on it.
No,
it's definitely not going to be, no, it's not harmful. It's definitely not harmful. It's definitely not harmful. But why do we want to drain out? Why do we add to, like Dr. Karun Agrawal says, why do we want to add to the VPD burnout? That is the
No,
only.
blowing a balloon or using a straw is not going to give them a burnout because it's not speech. So
No, but
like
they
you
won't
say,
understand that. Sir, they won't understand. We as professionals might know that, but as far as they are concerned, they will take it as an exercise for speech. They will say, they asked me to do all of this, but it didn't bring about a change. While
okay,
in reality, those don't bring about a change.
So
Can I ask?
So if questions are over,
Can I ask something to Dr. Mukunda Reddy, please?
Yeah.
Yes, sir, please.
Sir, after a primary furloughs, if there is a VPA, what is the procedure of choice?
I have had one in the last series which I did. I redo a furlough. It has been described that you can redo the furlough, and depending on the gap, I would do a suspension, because I have had success by redoing with a furlough in my own cases. Two of them, two were done. One was done by my colleague Rajesh, where I redid the furlough and the child has normal speech now. If the gap is more, then I would add a suspension to it.
Thank you.
Thank you. There's a question for Dr. Baljit. Sir, does keeping a post-op nasopharyngeal airway help to avoid potential airway problems?
Certainly it will. I think I had mentioned in my talk that placement of the nasopharyngeal airway, of course, it is going to prevent the tongue from falling back. But rather than the nasopharyngeal airway to be inserted post-operatively, it's a good idea to request the surgeon to place it electively before he comes out. Because if he is placing it there, I'm sure he will keep the nasopharyngeal airway in a manner that doesn't disturb his surgical line, that doesn't disturb the stitch line. But in case it is done in a situation when you are confused, when you are in a hurry, it's a desperate situation, you just force it in, the possibility is there that it might endanger the stitches, or it might open up the stitches from there. So I would prefer that in case you suspect that this patient is likely to have respiratory obstruction in the post-operative period, it's good to have the surgeon put it in before the patient is brought out of anesthesia. I hope that answers that.
Yeah, thank you, Dr. Baljit. Yes, Dr. Krishnamurthy. Yeah, Dr. Rebecca, I'll get back to you. Dr. Krishnamurthy is on mute. Dr. Rebecca, you're on mute. You can talk till then.
Basically, we have to realize that these children are used to air going in and out very comfortably before the surgery. Now, after the surgery, things change. They have a different feeling at the back of their throats. And very often, they're not used to this breathing. So therefore, we have to see how easy it was to intubate the child at the beginning, because that will give us some sort of idea if we have a problem after. And secondly, we have to make sure that there is no obstruction at the end. So a nasopharyngeal airway placed by the surgeon but checked by us, we have to make sure that the distal tip, patient's tip is above the glottis. And when both of us are agreed, then we fix the airway in position, check the length to which it has gone in, because that is important. If there is some bleeding and the suction has to be applied post-operatively, you have to see how deep the suction goes in. So that has to be kept. And you have to make a note that this is a nasopharyngeal airway, not a nasotracheal airway. The other thing is that if you've had problems ventilating the child at the beginning of surgery and there is some air in the stomach, an orogastric tube which sucks out the stomach will prevent vomiting at the end. So it's well worth doing that to remove air and whatever there is in the stomach before. And remember that when you have put this nasopharyngeal airway, it's not just for immediate 2 or 3 hours after, because edema can set in and there can be obstruction later on. So everyone has to be sure that the child is safe, the child is awake, breathing well, has good muscular tone before you remove that. nasopharyngeal airway. The other thing about supraglottic airway devices, you don't want something that you're going to shove in quickly, but LMA Supreme, which we have given to all our partners, it is very easy to put in and it goes along the tongue and anterior. So it's not pushing against the palate or against the posterior pharyngeal wall. So that is, I think, would be the easiest one to put in because the curve of the LMA Supreme is such that it's easy to place.
Thank you, Dr. Rebecca. Dr. Krishnamurthy, do you have a question? Or,
yeah, so no, I have an answer to the nasopharyngeal thing somebody asked,
okay.
Dr. Mukund. So this is what Philip Chen demonstrated, and I've used it in the beginning. So if you're worried about making the flap too wide or the port too narrow, this is not for the post-op airway. I'm talking about during surgery. So you can use nasopharyngeal airways on both the nostrils and put it in and raise your flaps between the two tubes. So that will give you the port size. And if you, he said in the beginning he would do it and not later on. So when we are beginners, when we are not sure how much wide the flap should be, we should place two nasopharyngeal airways on both the nostrils, provided it goes in, so that you cut between the two nasopharyngeal airways. So what is the size we use? That was the other question. You use the same size as the nasotracheal tube that will go inside. So when you intubate the child, supposing you are doing a nasotracheal intubation, what would be the size of the endotracheal tube? So when in doubt, ask the anesthetist and get that sized nasopharyngeal airway, put it right in the beginning, and then, like we discussed about post-operative airway, you can leave one or two of them in situ to prevent the problem that both Dr. Rebecca and Baljit have been talking about.
Can I add to that, please?
Yes,
sure, Narayanan.
Yes, so right from the beginning, from the Hogan's had described this use of these cannulas. So when Sir was doing the Hogan's itself, we used to put these cannulas on both sides. And after when we started the Chen pharyngoplasty, then also we have been using it on both sides. And if at all there is resistance on one side, then alone we do not use it on that side. But it's done as you say, we do it during the surgery, place it exactly so that the tip is beyond beyond the area where through the lateral ports, and the port is controlled with this cannula in place, and we remove it only the next day when we are sure that the patient is happy breathing, there is no difficulty, then only we remove it routinely.
Right.
Perfect. Thank you very much. One final question. There are many other questions, but I'm sorry, because of lack of time, we are not able to take it. Just one question for Dr. Krishnamurthy. Is there any procedure other than furloughs that you do? Then how do you decide?
Right. So I was a little bit rushed for time. I'll take a little bit more time and explain this. It is extremely.
I'm sorry to interrupt, but you'll have 2 minutes for this. I'm sorry, we're running out of time.
2 minutes is too much. I need 90 seconds. Yeah. So basically, someone like Dr. Mukund Reddy, who's a great innovator, looks at his results and comes in and changes things. We need to have an algorithm for lesser human beings like me. What do you do? So we had to do enough cases of furloughs to understand where it works and where it doesn't work. Today, we have established a formula, like it's basically about 0.3 to 0.4% increase in the closure ratio. So if you're in that range, post-operative prediction is more than 0.8 or 0.9% closure, you just do simply furloughs. But where you know that it is not going to suffice, then we do pharyngeal flaps, like a la the Reddy's suspension pharyngoplasty. And I don't have enough cases right now done and analyzed to know whether it works, but by the time I retire, I'll have a good algorithm.
Thank you very much, Dr. Krishnamurthy. Perfect. It was a wonderful evening with lots of questions. I know there are still some more questions that we've not been able to address here. We will address them by mails to the participants, to the people who have raised their questions. We will do that definitely. it's thank you all for making this session very, very lively with active participation.